Now we're going with the
Thank
next
you.
presentation. Professor Mathias.
Yes, I will talk now about carotid occlusion and stroke. And yes, as you know, when a cerebral artery is occluded, then per minute, 1 million brain cells will die. So time matters in everything in life, but here especially. Be fast. The prognosis of carotid artery occlusion with stroke signs is not so good, as you see. The mortality rate is, yes, in the range of 80 to 90%, and the mortality with a malignant MCA occlusion is up to 80%. Yes, we have different locations, even when I talk about carotid arteries. Yes, we have the internal carotid artery occluded. I like the stent retriever more than the aspiration devices because it can capture in a larger artery very well the thrombus. With the tiny arteries, it's more an aspiration thrombectomy, and very, very distal lesions you can consider if you want to use thrombolysis. So I think that IV thrombolysis does not matter because it's much too slow in an acute stroke. Also, intra-arterial thrombolysis for the carotid artery, it's too slow and doesn't make sense. Carotid endarterectomy can be considered, but you have to think of the fact that the thrombus is sometimes going fairly high up, and when the carotid artery is clamped by the surgeon, then you will lose the clot and it will go distally. So the treatment of choice is endovascular thrombectomy. Whom should we treat? You know, there are also patients who have an occluded internal carotid artery without any symptoms, an old occlusion. But we are talking here about acute stroke. So we have the clinical signs. We have then also to exclude hemorrhage and others. As you see, more than 80% of the patients with an occluded carotid artery and stroke signs have an ischemic stroke and not a bleeding. Yes, the diagnostic tool is CT. And then when CT angiography shows us, yes, what is occluded, how long is the extension of the occlusion, then we go to angiography, and that will be followed by the intervention. We have two types of carotid artery occlusion. We have the distal T occlusion, and we have the disease of the carotid bifurcation with stenosis, and later on, when the plaque is unstable and thrombus is formed, then you have an occlusion at that level. Also a reason why not all the patients can be treated surgically. Yes, as I mentioned, I like the stent retriever in the larger arteries because often with one extraction I have the clot out. When it is in the carotid artery, you place a balloon-tipped sheath or catheter in the common carotid. You place also a balloon to occlude the external carotid artery. Then you go up with the stent retriever to the clot. And when you start to retrieve the clot, then you block the common carotid artery, so you have no antegrade flow anymore. You can even produce an underpressure, combine clot retrieval with an underpressure on the artery. When it is far up, but that's not what I'm talking about today. I will not go into detail of all the technical steps, but I will show you at least here a sketch. So you have this carotid artery occlusion at the level of the bifurcation. I do stenting. Professor Grunwald already mentioned, yes, when you stent, and be careful with stent retriever. Therefore, I then advance the sheath or guiding catheter into the internal carotid artery, and so then I have passed already the stent, and the stent retriever will not catch on the struts of the stent. Some examples. 49-year-old female patient, acute hemiparesis. The time window in the past played a major role when I look back 30 years. Some of you were not born at that time. We had thrombolysis as only treatment modality. And the neurologists then found out, yes, when you have a time window of 6 hours, you have some cerebral hemorrhages. So they cut it down to 4 hours, but that excludes quite a lot of patients. And therefore, the time window matters. But today, with our imaging techniques, I think don't be fixed on the time window. It is more important to look at the brain. Is it in good condition, or is there already quite a lot of dead tissue? And that is a decision. So I have treated patients also after several hours. Yes, you see in this example, yes, the left hemisphere is underperfused. When you look at that, yes, where is, I don't know if you can see it or if I can show it. When you see there is the calcified carotid artery here, but it's missing there. So occluded. But also the middle cerebral artery has a problem, as you have seen. So we opened that up step by step, the internal carotid artery. You see there is still some stenosis there in the distal internal carotid artery and no flow in the MCA. So we have these spasms in the distal internal carotid artery due to the stent retriever, and we don't have the middle cerebral artery. So we also have to get out the clot from there. And that is when you have embolization, not so rarely, that you have not only the internal carotid artery occluded by thrombus, but there might be also some thromboemboli farther distally. And you see, yes, we solved that problem. Yes, spasm resolved. And then you see, yes, there is quite some material of clot coming out. Another patient, only 19 years old, so you have not to be at an old age to develop a stroke. Time window more than 5 hours. And CT is showing already there is brain edema. And also a white spot here. Is that already bleeding? Yes, we have a carotid T occlusion. So when you look at that, there is no carotid artery, but also the MCA is occluded. So also here a combination of both. And you see that we went up and could open the carotid artery, but we still had the problem with the MCA. You see we could also open up the MCA and the anterior cerebral artery. Clots retrieved. Control. Angio with CTA after 1.5 days. Good flow restored, but brain edema, and so you needed a craniotomy to decompress the brain. 66-year-old lady, also hemiparesis. You see carotid artery occluded, thrombectomy, everything okay. But also here, the MCA occluded additionally. So we also opened up that artery, and very good. The following day, CT, you see no signs of bleeding or of stroke, no infarction, and clinically completely asymptomatic. Only MRI showed 2 signal intense spots, that's all, but that's asymptomatic and will disappear within a couple of days. So, a 64-year-old lady, yes, again, when you look at it, only 1 carotid artery is seen, but additionally also a typical sign of MCA occlusion, dense media sign. So you have both the carotid artery occluded and the MCA. CT or MRI study here shows, yes, a fairly good image. There's only a little bit in the right MCA area underperfused. And we opened that up. There's still some narrowing then distal to the bifurcation, but we also treated that with an exact stent. And at the end, we opened it. There is a little bit of thrombus also in the MCA, which we removed, and we had a good outcome at the end. So we have treated over the years more than 1,800 patients, and I conclude outcome is determined by draw to reperfusion time, but not only, because the collateral flow is individually different, not only with the circular villus, but also within the brain. And then team approach, yes, it's clear. Co-work with radiologists, with neurologists, with the interventional team, and so on. Yes, then, as you see, the time window is not decisive anymore today. What I want to mention at the end, because it was also addressed by Professor Grunwald, is blood pressure management. Why is it so important? Yes, because when you do the intervention in general anesthesia, you have already, before everything starts, to inform the anesthesiologist. Keep the blood pressure up, because general anesthesiology, normally the blood pressure is going down, because in general anesthesiology, the patient is relaxed and the blood pressure is falling. So he has to keep it up, systolic 160 to 200. But when you then have removed the clot and have a good reperfusion, then you have to tell the anesthesiologist, get the blood pressure down. And that should be done immediately. So when you open the balloon of the sheath in the common carotid artery, and you have a normal flow, before I open that, I will tell him, get the blood pressure down. A systolic blood pressure of 100 to 120, yes, should be good. And then I opened my balloon, not to get any brain damage due to reperfusion. And so now I thank you very much. Yes, I like swimming, and therefore I show you an image of that.
So, scenario. Patient arrives with symptoms of an acute stroke, hemiparesis, right arm, weakness right leg. You do the imaging intracranially, no occlusion, but you see a 99% carotid occlusion. Not complete occlusion,
yes.
High-grade occlusion. Should we treat?
I do that, certainly.
80% would you treat? Acute symptoms,
yes,
acute onset of symptoms?
The question is, by 80%, is that only a TIA?
Yeah.
Yes. But then it's a symptomatic patient, also 80% I would treat.
Perfect.
Yes,
okay.
with steroprotection and stenting at the lesion and medication, as you have mentioned, with platelet aggregation. I would treat it.
I think here really, really important also to look at the blood pressure of the patient. I would definitely always treat the patient because the patient has become acutely symptomatic Usually those patients still have a high blood pressure that keeps it, and if they go to sleep, the next day they wake up, blood pressure dropped during the night, and they wake up with a complete hemiparesis. So really important here to know that even if it's not a complete occlusion. Yes, so totally agree with you. Thank you very much, Klaus.